Multicenter Perioperative Outcomes Group.
Thank you. Okay, well, thanks everybody for having me. As was stated, I'm a cardiac anesthesiologist at the University of Michigan. I have a research focus on using data science methods to improve care, which is what we'll be speaking about today. So as far as some disclosures and conflicts of interest, I'm disappointed to not yet be at a stage in my career where I've been courted by every industry, but I'm fortunate to have some research funding through grants. And also, as much of my work relates to outcomes research, it's worth noting that the University of Michigan is the coordinating center for this outcomes group that I'm the research director for. And so I'll get into some of that in my talk here. So to outline my talk today, I've divided it into 3 parts. The first part will be just talking about kind of where the electronic health record data stands with perioperative records, meaning data immediately before, during, and immediately after surgery, and kind of the recent advances that we've made there. And then I'll be talking a little bit about frustrations that we've had as the research director for this group, kind of in understanding the perioperative EHR data, and a couple ways that we've tackled these problems. And one of the things I want to just the electronic health data to groups that aren't just anesthesiologists and aren't just computer scientists, and get a little bit into how we've integrated different electronic health databases to answer questions that any single database alone would be unable to answer. So my approach to this talk, I think compared to other talks that I've seen given in this seminar, it's not going to be overly technical, but rather I want to focus on bridging the gaps between clinicians and methods experts that become very obvious to me whenever I watch a conversation happen between a clinician who may not necessarily be a data scientist and a data scientist who may not necessarily understand all of the clinical nuances of a problem. And the way I break it down is I think each group has a superpower and a fatal flaw. Superpower of clinicians is they understand the nuance of a clinical problem. They take care of patients every day, and they understand when a patient might be a representative of a very common disease presentation, or there may be different cases where patients have they're a kind of a rare set of comorbidities that the clinician can pick up on and develop more accurate treatment and diagnosis. But when I see clinicians interact with data scientists, one of the things I see them fail to do is codify their assessments and their judgment. They're very used to the art of medicine and less used to explaining their judgment and assessments in a way that can be put into a computer program. And so it's just one example is a clinician might say this diagnosis only happens in children. Well, what do you mean children? Do you mean 0 to 18 years old? Do you mean toddlers? Do you mean teenagers? There's this kind of tragic underspecification of data definitions that I see clinicians make when they're trying to interact with methods experts. On the flip side, the methods experts, they know how to handle big data, how to handle missing data, redundant data, corrupt and different invalid data, and they're very well trained in the different methods for prediction modeling or multivariable analysis, but they can often focus on the wrong details. They certainly are familiar with the health setting, but there may be a certain level of clinical nuance to a specific problem that leads them to focus on and sometimes focus on the wrong things. So I think they complement each other, but you have to recognize your strengths and your weaknesses to be able to solve these problems.
Quick question.
Sure.
What's your own background?
Yeah. So I am I'm a clinician primarily by trade. I have I like to think that I understand a little bit of the data science methods.
No. He's a data scientist, a biomedical engineer, and understands every side, both sides. He's bilingual in both fields. It's just being too modest and humble.
But you are brilliant on this side, then learn the other one, or vice versa?
So right now I spend 25% of my time in the ORs taking care of patients getting cardiac surgery, and then I spend 75% of my time over at the NCRC. Have research funding to use data science methods to develop prediction models for cardiovascular disease. So that's kind of, but I've seen this conversation happen, and I've seen clinicians who are similar to me that have enough data science training to be dangerous, but don't necessarily fully appreciate the nuances of the different methods. Interact with data scientists, and it can be good and bad. You have to learn how to have these conversations. That takes a lot of work. Just a couple of examples of successes in using big data in perioperative care, which is anesthesia. We've been able to, over the past couple of decades, study rare diseases and complications. One example is postoperative visual loss, where a patient wakes up blind after surgery. This happens very, very rarely, on the order of 1 in a million cases. And you can't really understand it unless you have a large data set where you have a number of these patients in your data sets. So just these very rare idiosyncratic diseases we can study when we have access to big data. We're also able to model complex processes. So going under anesthesia, in some ways, is a lot like falling asleep, and in other ways, it's completely different. And being able to model your brainwaves, your EEG signal, while under anesthesia is something that we've been able to do through handling big data in anesthesia. Been able to develop institutional and national benchmarks. So we've been able to compare providers within an institution on certain quality measures. We've been able to compare institutions across the state, country, or world, and kind of characterize differences in practice patterns and opportunities to improve. And lastly, we've been able to support a precision medicine platform. So we've been able to understand specific patient risk factors for postoperative complications based on our knowledge of the population and also our knowledge of the patient right in front of us, how this patient might differ from the broad population, and what we might need to do differently for this patient right in front of us compared to the broad patient population. So in anesthesia, have come through our access to big data, which includes a number of different types of electronic health record data. There's physiologic data. We can answer questions about what's the prevalence of low blood pressure during surgery. There's medication data. So we have every patient getting surgery usually gets some dose of pain medication, opioids. We can calculate the average dose of opioids that patients receive for a specific type of surgery at a specific center. We've been able to look at discrete events. So when a patient goes under anesthesia, usually you have a breathing tube in place. Sometimes it's very challenging for the anesthesiologist to put that breathing tube in, and they'll document the difficulties there. And that can be certainly a life-threatening issue when it happens. But just documenting specific events that discretely happen in the OR, we've been able to amass data on that and understand ways to improve. And lastly, we've been able to look at center-level data. So again, we can characterize practice patterns at one center and compare it to another and identify potential opportunities to improve. So what do we do with all this data is a question that's commonly answered by the clinicians. And one answer is using a learning health system. It's a term coined by an informatician actually here at U of M, Chuck Friedman, at the School of Public Health. But basically it takes, you start at the bottom, you have a hypothesis, you can use your access to electronic health data to test your hypothesis, and eventually you'll get to a journal publication and you'll disseminate the results. But then there's a whole implementation arm to that as well, and that's kind of the right half of this figure, where you can develop different toolkits for quality improvement, develop best practice advisories, and you can disseminate those, and you can improve care and then develop new hypotheses about what best practices might be. So there's this left side of the image is kind of the practice data to knowledge or research, and the right half of this is just transforming your knowledge to practice, and it's commonly called quality improvement. So one example of a learning health system applied to the specialty of anesthesia is a group called the Multicenter Perioperative Outcomes Group. It's a group of clinicians, informaticians, and quality improvement champions that are across the country and are united by the shared goal of using anesthesia data to improve care. And there's two major arms. There's the research arm and a quality improvement arm called ASPIRE, standing for the Anesthesia Performance Improvement and Reporting Exchange. And I don't necessarily want this to be the focus of the talk, but I do want to use it as an example of how we can make electronic health record data actionable. So through the lens of my experience with this group, I want to just use this as kind of a microcosm to addressing problems with handling health data. So this group it's a group of over 50 hospitals from across the country. It's both academic and private practices. We have over 140 million intraoperative records in this database, 21 billion physiologic observations, and we have very high granularity. So we have minute-to-minute blood pressure data, medications administered minute-to-minute, fluids, ventilator settings. So it's a very granular data set, which makes it somewhat unique compared to other health data sets. Here are some of the sites that it's concentrated in Michigan because we have Blue Cross Blue Shield of Michigan funding to support this. It's part of our funding, but certainly we have other major academic centers on both coasts involved in our group as well. Some of the accomplishments that we've been able to achieve through access to this data is we've been able to look at descriptive studies, literally just describing practice patterns and how they vary from one institution to another. We're able to look at operational analyses. So, for example, we can look at if different institutions set alarm limits on their drug infusions. We can kind of understand that. There's a recent study in JAMA looking at overlapping surgery. It's kind of a politically charged concept that a surgeon may be finishing a previous case, and the next case that surgeon is doing is going to be starting in an adjacent room. He's going to once he finishes the critical portions of the previous case, he will have an assistant finish that case while he moves on to the next surgery. So there's all these different operational analyses that you can study through access to our data. And then there's outcomes and just traditional outcomes research. We can look at electronic health data just limited to our database, or we can also look at electronic health data that is within our database linked to surgical outcomes registries. And a number of different surgical subspecialties that have outcomes registries that we've linked our data to understand what are the intraoperative practices that we do that impact how patients do after surgery. So we've been able to do that. And then lastly, we've been able to provide the backbone for a clinical trials network in anesthesia. There's many other subspecialties in healthcare that have been able to set up clinical trials networks. Anesthesia has been kind of late to the game in doing this, but through the work of our group, we've enabled a couple different projects that will be up for NIH grant funding, hopefully in the near future. So each of these studies wasn't without. Go ahead.
Are you doing detailed studies of well-established drugs in the face of individual variation? Or new drugs? What are some of the successes?
Yeah, sure. Yeah, sure. So
that later.
Yeah, absolutely. Yeah, one of the I'll be honest, it's still in its early phases, but some of the projects that we've started. One is just looking at opioids, being that's a major healthcare problem that's received a lot of public attention. It's certainly something that an anesthesiologist is well qualified to speak on. But we've looked at implementing tailored opioid management strategies to patients that are on high doses of opioids coming in for a surgery. They're going to have a lot of trouble with their pain management, and so we've worked on developing a team that can have individually tailored opioid management strategies. So I guess to answer your question, it's probably very common.
I think it's Paul Hilliard
has
been studying tapering doses in patients who are already preoperatively opioids to try to get them down and maybe off.
Yeah, absolutely. Yeah, it's a huge challenge. Yeah, and yeah, Paul Hilliard, is a colleague of mine. He's done some great work in that area. But it's a huge challenge trying to get patients off of opioids. Hopefully, we can get their opioid tolerance or their dose of opioid reduced before they have the surgery, because that's going to have an acute bump after the surgery, and being able to handle that without having all of the complications related to the side effects of opioids is a huge problem. So being able to study some common drugs, I guess most of the trials that we've set out on are more I guess not the drug development kind of phase. Is more the outcomes and kind of the kind of later spectrum of the translational research is more kind of focused on clinical care. So each of these studies that I mentioned on the previous slide wasn't achieved without significant pain and effort because of a couple of different obstacles that are not unique to our anesthesia electronic health records, but are ubiquitous across all electronic health records. And if anybody that's worked with health data, it's very messy. It's often incomplete. It's often redundant. In anesthesia records, sometimes patients have, for instance, a blood pressure reported from multiple different sources. You might have a cuff on your arm, but you might have an arterial line in your wrist. And how to resolve redundant data is an issue. That data might be conflicting. So you might have a blood pressure that's 20 points different on your arm compared to your wrist. And so how do we resolve conflicting data? And sometimes it's just inaccurate. So sometimes, for instance, this blood pressure monitor in your wrist might have the pressure tubing might have a kink in it, and you're going to really not be able to. The anesthesia provider is not, recording the fact that this is artifact right now. So you get all this physiologic monitoring artifact in your data, and you get this inaccuracies across all forms of electronic health data. And the second challenge is that getting people to change their practice is extremely difficult. There's a famous quote in informatics that it's 10% medicine, 10% technology, and it's 80% just getting people to agree on what is best practice and what we need to do differently. And that nudging of clinicians is a very challenging part of implementing. You may be able to develop research projects and understand the data more, but if you can't get clinicians to actually change their practice, you can be in a lot of trouble. So that's often the hardest part of this whole process.
I met that guy. He's important all the time.
Yeah. Oh yeah. Absolutely. So we all know that in the area of big data, more data isn't always better if we don't have a way to digest it. And that's often what I hear from clinicians is that they don't want to be bombarded with data. They just want to, give me some high-level inferences from all of the massive amounts of data that you're taking in, and give me a couple clinical actions that I can consider taking. So that's kind of a fundamental problem with electronic health data. And so rather than give a comprehensive overview of how to solve this problem, I'm going to go through a couple examples of problems that our own group has encountered and ways that we've solved these issues, or at least tried to mitigate these issues, and as kind of as an example of ways to get around these problems. So one of the problems is that data are non-standardized. So you might have a hospital system here in Michigan that uses Epic, and then you might have another hospital system using a completely different vendor in California, and getting them to be there's this issue of semantic interoperability where you can't really compare apples to apples unless you have that data in a standardized form. So this issue of being able to make fair comparisons across hospitals that have different vendors or different documentation patterns is a challenge. And the sheer massiveness of the data that we have is an issue. So in the anesthesia record, you usually have about 2,000 physiologic observations from 40 different data streams. You can multiply this 2,000 by about 100 or so if you factor in waveform data that we now have, at least at the University of Michigan. Another issue is that the primary purpose of electronic health records is for patient care. It's not for doing research projects or quality improvement projects, so that the provider that is recording the data isn't really thinking about this research trial that you've come up with 5 years after the fact, after they've cared for this patient. They need to care for the patient in front of them, and they're not necessarily making the tidiness of their data the number one priority, right? So just using myself as an example, when I'm taking care of a patient undergoing cardiac surgery, I'm focusing on taking care of that patient. And when you're coming off bypass, it's a very tenuous time. It requires a lot of attention. There's a very high cognitive burden to taking care of that patient at that time. And going and documenting in the EHR at that time is just not my number one priority. And then going back and getting that data entered accurately can be challenging too when you have a very high workload. So this issue does definitely impact the quality of electronic health data, and if we don't realize this, we can come to misguided conclusions from our data. So the example problem that I want to go over with this group is a problem that I've tackled in a couple of my own research projects. And from a cardiac anesthesia perspective, I've wanted to look at different management techniques both before and after cardiopulmonary bypass. So there's a period in any cardiac surgery in the middle where the patient's on a heart and lung machine, and being able to differentiate between before, during, and after is something that I'm very interested in. So the task is to do this and also do it at 3 different hospitals with 3 different electronic health record vendors. So as I mentioned, there's 3 phases to every cardiac surgery. There's the first phase, which is the patient is using their lungs and heart to support their breathing and their perfusion of blood to their vital organs. In the middle, you have this phase where you're on cardiopulmonary bypass. It's a very tenuous phase of the surgery as a perfusionist managing the heart and lung machine. But it's a very high intensity, high acuity phase of the surgery. And then at the end of the surgery, they come off the heart and lung machine and they go back to using their own heart and lungs to support themselves. So there's one of the challenges I'm trying to come up with, or one of the challenges I'm trying to address, is how to reliably identify these 3 phases. And another challenge is trying to compare 3 hospitals with 3 different electronic health record vendors. How do we make fair comparisons across hospitals? So those are the challenges. And so what our group has taken a step back and thinking about how we can address this challenge. What our group has considered is there's a couple different ways, starting with this first problem of just detecting when a patient's on a heart and lung machine or when they're off. That there's a couple different ways that we've come up with figuring that out. One way is to just look at what the anesthesiologist is typing in the intraoperative record. So they'll very often enter, or sometimes they'll just click on a little checkbox that says, yes, the patient is starting cardiopulmonary bypass at this instant, and yes, we're coming off bypass at this instant. And when that's charted, it's usually reliable. But the problem comes when you have to realize that the way anesthesiologists chart this is different at different institutions. And also, sometimes when a patient has to go back on bypass, if there's some complication during the surgery and we have to emergently go back on bypass, usually that second or that third time that you're going back on bypass, the anesthesiologist is not reliably documenting that start and stop time. And rightfully so, they're focused on the patient care at that time. The other way that we've worked on detecting cardiopulmonary bypass is through ventilator data and physiologic data. So when you go on the heart and lung machine, you don't have to be breathing at that point. So our ventilator is off for the most part, not always. There's specific edge cases where we would not necessarily be turning our ventilator off. And your blood pressure is going to become continuous rather than pulsatile when you're on bypass. When your heart is beating de novo, you have a systolic blood pressure and a diastolic blood pressure. When you're on bypass, the bypass machine is just a roller pump, and you have one continuous blood pressure. So in theory, you could look at the difference between your systolic and diastolic blood pressure, and when that comes close to 0, you could infer that you're on cardiopulmonary bypass. And again, there's a whole host of different edge cases and exceptions where that may not necessarily be the case. And And then there's this transition phase. You don't know exactly, the switching on cardiopulmonary bypass and off isn't done in one instant. It's done over the course of usually 5 to 10 minutes. So our plan here is just a hybrid approach of both. We looked at anesthesiologist documentation as kind of a first pass to catch maybe about 90% of this, and then to catch the other 9.9%. We don't have perfect, but we're getting there. We use ventilator and physiologic data as kind of a second pass. And so just focusing on the anesthesiologist documentation part of this issue, let's just say we have 3 different sites. They document different variables in different ways. Sometimes they're similar, sometimes they're very different, sometimes they're missing specific data elements, and sometimes these are overlapping, sometimes they're not. But we need some tool to take all of these local EHR documentation and convert it into a standard concept that's semantically interoperable across sites, and we can make these comparisons. So we've created this tool that you don't need to be a computer scientist to use, called the concept mapping tool. And what we've had for every institution participating in our group, they need to have an anesthesiologist and a kind of an IT personnel working together, mapping all of their local EHR concepts. In this instance, I use cardiopulmonary bypass. They can search for their concepts in their local EHR, and then they can map them to MPOG-wide standardized concepts through this tool. It's an arduous process, but once you get through doing this, you don't have to do it again. You don't have to update it with new medications or new practices, but it's becomes a very powerful tool for them making fair comparisons across sites.
Mike?
Yep.
How would you compare the capabilities of these tools to something like I2B2 that has like a general purpose cases? They're not probably designed specifically for surgery, for pre-op or intraoperative surgery, but do you see some capabilities that can be added to those kind of,
I think there's, the way that we've gone through solving a lot of these problems is through like different rule-based algorithms, but eventually it would be great that we could start developing machine learning approaches to just predict, I guess, when a specific variable, when a specific variable at one site is likely to be a specific standardized MPOG concept. So it's definitely in our future. I think if I'm getting at what you're asking, one of the ways that we're trying to do that right now is we have a when a surgeon books a case, they go to the OR front desk, they write down the name of their surgery, and then and that gets entered into our the information, the anesthesia information management system, and the case gets assigned and we do the case. And then a couple months after that, a billing specialist goes in and assigns a specific CPT code, a billing code to that case based on looking at the title of the surgery, looking at this, the specific surgeon and the patient. And one example of us helping alleviate that issue, that delay of about 2 months, which can actually be costly, and using a billing specialist is certainly not cheap. We've been able to work on a machine learning algorithm that uses natural language processing, looking at the specific words in the case booking, and can give you instantly, it can predict what the CPT code should be. And we found that it's actually more accurate right now than most of the billing specialists' diagnoses.
But you created this independently by yourself for this study.
Yeah, I don't want to take too much credit. I didn't do this myself, but our group created this tool that, again, our goal is to create tools that an anesthesiologist who's not necessarily a data scientist or a data scientist who doesn't necessarily understand the clinical nuance of specific terms can use. And so
I think I2B2 doesn't have that capability and doesn't use natural language processing. They for general purpose kind of like hospital operation and databases, they have some sort of matching and typically based on financial codes to match these things with each other. I'm seeing if this thing becomes, something more comprehensive, it would be a good idea to start with I2B2.
Sure.
To maybe make it a component in I2B2, which has an organization,
Sure. Yeah. I think that's a.
Well, I think a big part of the success of this ideology or operative work of the last 5 years has been to focus specifically on this. It's a very high volume, high risk operation. Things happen in minutes and seconds compared to a day of a visit, which is sufficient for some other information I could be to. And it could be a segment
right.
of a much larger generalist system.
Yeah.
But I think it's got many, many special features, mostly around the detailed physiology and the timing.
Yeah.
Is that fair?
So for people watching at home, the comment was basically about the relative strengths and weaknesses of the MPOG data set. We do have the very granular data. I think the strength of the thing that we offer that's different from most other health data sets is the granularity, the minute-to-minute level of data. And the potential drawback is that this is a very brief. It's certainly a high risk, very important part of this patient's medical care, but it's a very brief encounter. We're not essentially capturing the full nature of this patient's chronic disease trajectory, and that's captured more with the integration to other electronic health databases or surgical outcomes registries, and that's been a focus of our group over the past few years. Yep.
So my question is, I understand this is a mapping of concepts from different systems. Of course, it's related to machine translation to Montreal, that will be bilingual, French, English, Hong Kong, Chinese. But these are all English, but in 3 different semantic systems.
Sure.
My question is about not only mapping concept, but also mapping of actions and judgments, or how they make decisions on those information. What if the 3 sides also have different preferential weighting of evidence?
Sure.
How do you capture that?
Yeah. So I'll get into maybe a little bit of that in a few more slides. It's very difficult to capture or even codify judgment of the provider, but we are able to take specific concepts, just one specific variable, combine it with other variables to make higher level inferences, and that's I'm going to get into that in just a few slides, talking about, and I call these phenotypes. It's just different ways that, for instance, disease processes might manifest in the electronic health record. You might have more than one way to figure out an answer to a specific problem. Yep. Yeah. Okay, and so very getting back to our problem of detecting cardiopulmonary bypass, we have a very simple, from the perspective of a data scientist, a very simple rule-based approach for detecting cardiopulmonary bypass. If you have a very small pulse pressure, where the difference between your systolic and diastolic blood pressure is low, or your heart rate is extremely low, we suspect that you may be on bypass. But we also have to check the ventilator data, and you have a very low respiratory rate or end-tidal CO2. When you exhale, you produce carbon dioxide, and you can measure that. And if that's very low, it's likely that you're not breathing and you're on cardiopulmonary bypass. So we use this kind of very rudimentary rule-based approach to get the quality of our data in detecting cardiopulmonary bypass. It's not at 100% yet, but we're taking it from 90% if we just relied on the anesthesiologist to document, to 99.9%. Is kind of our goal here.
Mike, are there cases that you use that and you go and you have to correct, not only add to the documentation, correct the documentation?
Yeah. So one of the things that we've talked about doing is creating, and Vanderbilt has done this with their electronic health record. They've actually created a avatar of their electronic health records. It's an exact carbon copy that is then is kind of curated by a researcher. And you've cleaned out some of this artifact, or you've fixed issues where you have conflicting data. You've come up with some algorithm to resolve conflicts, fill in missing data, filter out artifact. And we haven't yet done that as we haven't transitioned to using an entirely separate avatar, but on a project by project basis, we've come up with different algorithms that I'll get into in additional slides that get at that issue of of taking, I guess using higher level influence, higher order inferences to answer specific clinical questions. But it's the idea of just going back in and curating the record. It's definitely, there's some medical legal implications there. So you can't just create a rule and not expect it to have. There's certain unintended consequences of doing that. Right. So we have to be mindful of that, and that's kind of the major kind of push and pull with auditing your medical record. So what we've looked at here, just getting back to this example, is there's two different ways that we've answered the same question. We've looked at anesthesiologist documentation, we've looked at ventilator and blood pressure data, and we've developed kind of a higher order inference from these concepts. So what we've done at MPOG is we've taken these combinations of raw data, we've put them through kind of a logic circuit, and we've developed these higher level inferences about what's happening in the health record. And cardiopulmonary bypass, just recognize that's just one example. We've done this for hundreds of different other processes of care in our records, and these serve as kind of Lego building blocks that researchers, quality improvement champions can then reuse. We found that this idea of detecting cardiopulmonary bypass is not just a problem that I'm interested in. It's a problem that many different researchers are interested in, and they shouldn't have to reinvent the wheel to do that for their research project. They should be able to trust the hard work that that one other researcher put in to develop the phenotype, and not have to spend the kind of the arduous time and effort of curating the data that same way. So we end up having both what we call a concept browser. We look at one specific data point, and it's a searchable database that we have on our website, and you can look for very specific granular data. But we also have a browser looking at phenotypes, which are, again, these higher level inferences about processes of care derived through a kind of a logic circuit of combining different types of raw electronic health data. And so we make that a searchable tool that anesthesiologists and researchers can use when they develop research and quality improvement projects. So this idea, and it's been really fun to be able to kind of give people access to this data. A lot of times we find that 95% of your effort is trying to get access to the right data and curate it in the right way. We want to take that away and make the 95% of your time actually doing the interesting research study that you are setting out to do. So so this concept of digital phenotyping, it's not just in anesthesia. It's pervasive of all of electronic health records. But basically, it's just a way to observe a specific characteristic of a patient through their interactions with the environment. And in electronic health record data, this often is the manifestations of a disease process. So just two quick examples. Patient with type 2 diabetes, you can figure out they have diabetes based on, first and foremost, that they have a diagnosis in the electronic health record. That's an obvious way to detect it. But there's many other ways. You can look at their lab values that are also in the electronic health record, and if the majority of them are above a specific threshold, there's a good chance that patient has diabetes, even if they don't have a diagnosis of diabetes listed in the record. If they're on a medication for diabetes, obviously that's another way to infer that they have diabetes. Blood pressure, kind of the same thing. If you have a diagnosis for it, obviously that's a good way to detect it. You can also detect it with vital signs or with medications for high blood pressure. And so you can do this with a bunch of different health record data types, each having their own strengths and limitations. I won't go through all of these for the sake of time, but using all of these different data types, you can combine them into kind of logical operations that will give you better labels for your data. And these labels, these phenotypes are stored right now. One collaborative that is working on these types of phenotypes is the Phenotype Knowledge Base. You can go to this website. But they are working on getting groups together to agree on, well, what is the best way to diagnose hypertension in the medical record? How do you diagnose a patient with heart failure? And they've created these algorithms to give you better labels for your data. And again, I won't go through all of this, but this is this is one example of a phenotype for atrial fibrillation. So they check if there's a diagnosis there. That's the first check. But then they look for medications for atrial fibrillation, warfarin or digoxin. And if those are present and they've confirmed that the patient is not taking those for another diagnosis, then you can infer that this patient has atrial fibrillation. Type 2 diabetes, same thing. You're looking at the diagnosis codes, the medications that you're taking, lab values, also the number of times it's diagnosed. Sometimes if you look at especially with diseases that have waxing and waning courses, sometimes a patient might have had heart failure related to some rare virus that they had 10 years ago. Their heart failure is now resolved. That patient may have had heart failure diagnosed by one physician at one time 10 years ago. And if they don't have multiple physicians corroborating that diagnosis over time, you are less confident in that diagnosis. So the number of times that a diagnosis is made is also valuable information as to the confidence in your label, type 2 diabetes. Heart failure is another example. You can look at lab values, medications, you look at the clinical notes and diagnosis codes. So you can do this retrospectively to help improve prediction algorithms. You can also just do this. You can just do this in real time prospectively to figure out. Sometimes you have patients that obviously have a disease but just have not had the diagnosis. And I thought this was one pretty elegant study looking for what they call hypertension hiding in plain sight, where it's just a patient that has never gotten the diagnosis of hypertension. Maybe they went to a dermatologist's office. The dermatologist, removed a mole, but took their blood pressure. It was 160 over 100, and didn't really do much about it because their focus was on getting that mole removed. You accumulate enough of these vital signs, you can have patients that clearly have hypertension that have just been missed by the healthcare system. And using a kind of an automated referral system, you can get these patients to see their primary care doctor or cardiologist to get them started on hypertensive medications that will have been proven to improve their quality of life and their lifespan. And then kind of getting into a little bit what I was talking about earlier, you can do rule-based algorithms. You can also, the next step is really just training a machine learning algorithm to predict these diagnoses. In this case, this example here is predicting monitoring artifacts. So it's not a diagnosis per se, but just when a set of vital signs is likely to be artifact versus when it's likely to be a real life-threatening issue is very important for intensive care units and anesthesiologists in the OR to be able to identify. And so a way of identifying artifacts using machine learning approach has been developed and published in this study. But certainly machine learning to predict diagnosis, I think, is another interesting step that we should be taking in the near future. So the last part of my talk is just opportunities ahead. As I mentioned, there's a gap here. Clinicians aren't necessarily data scientists. Data scientists often may not understand the full clinical nuance of a problem, and furthermore, they may not have access to the health data that they would like to have access to implement their methods. So a solution to this problem has to be able to be available to anesthesiologists who have no idea how to use SQL or R or SPSS or any or Python or any programming language, and you need to have an ability to have data scientists give them a path to access the data in a way that doesn't require them to be a first-degree relative of your hospital's chief medical information officer. That'd be very helpful too. And so our approach, and it's very similar to, is this room familiar with Data Direct kind of in our hospital enterprise? Sure. We've done the same thing for our anesthesia records, for the MPOG database. We've developed our own version of Data Direct, and very, just as with the University of Michigan's Data Direct, you can very quickly develop a cohort of patients that is kind of a rolling list of specific characteristics that you are checking off as an inclusion or exclusion criteria. And you can very quickly develop a cohort of patients to study and get access to this data with IRB approval. And so just in this example, I just very quickly, it took me roughly 30 seconds to do. I've answered the question of how many patients, how many adult females that are undergoing a non-emergent, non-cardiac surgery with general anesthesia that have hypertension, diabetes, and renal insufficiency of kidney disease received a very common medication during surgery called propofol. And we found that we have 400,000 patients and 555,000 cases that fit these criteria. So it's a useful tool to identify a cohort, and then we have the ability to access this data. And again, for an anesthesiologist who doesn't code, an Excel spreadsheet is then the way we've been able to have them access the data. We have the two modes, and you guys may already be familiar with this, but we have the cohort identification mode where you can just understand if the study that you're proposing is even feasible. Do you have the adequate sample size? You don't need a IRB. Your site participating in MPOG needs an IRB and a data use agreement with the coordinating center, but you personally, to do the study, as long as you're at a participating institution, you don't need an IRB to do this cohort identification. And then the data download mode is when you can actually access the health data. We, as a group, have decided that any investigator at a participating institution has access to their own health data at their hospital. And then with approval from our research review committee, we will give you access to the multi-center data after you've presented your research project to our group. And so that's kind of the way we've been able to democratize access to health data. We've also integrated health data. So there's a number, besides just the anesthesia record, we've been able to take just as available in data direct different other electronic health data and combine it to, I guess, drive more powerful research studies. We've been able to look at case information, diagnosis codes, demographics, anthropometrics, and the anesthesia history and physical. So the anesthesiologist before any surgery will do a brief history and physical exam of the patient. We have access to that data. The intraoperative data that I already mentioned before, the medications, fluids, events, physiologic monitors, ventilator data are all there. And then postoperative data, so we have lab values, I guess before surgery and after surgery. For every surgery that's in our database, we have lab values 365 days before and after. We have discharge diagnosis codes. We have the professional fee data, so as I was talking about, the CPT codes. And we have data on in-hospital mortality. And so using all of that integrated data and through this MPOG Data Direct tool, we've been able to set up a formal review process for clinicians or data scientists that wanted to do studies. This is on our website, kind of the step-by-step process that you go through. And we have, just like clinicaltrials.org is a website for registering your study before accessing the data set. We register all of our research projects on our websites as is required by many medical journals. When you get your data, you also have a ability to visualize your data. You may be able to do this on your own, but we recognize, again, that many clinicians aren't very data science savvy, and we give them ways to understand, give them insight as to the quality of their data. We have this tool called Data Explorer, which gives you just different, very basic visualizations of different data elements that you queried. This data element is your baseline mean arterial pressure, but basically your average blood pressure at the beginning of surgery, and you can look at it through different tools, different visualizations to understand if there is some, if the data kind of passes a sniff test, does it make sense, or is there something some aberration in the data that you want to drill more, take a deeper dive into. We have the ability to do that first with this Data Explorer tool. It kind of gives you a bird's eye view. And then we have this case-by-case audit tool, which in the case that you may have found some interesting outlier group of patients in your data set that seems different fundamentally from the majority of your data set, we have this case-by-case audit tool where you can search a specific element in your data within a specific date range. You can specify a specific institution and get a random sample of these cases meeting whatever threshold you've set. So in this case, again, I'm looking at a patient. I'm looking at the variable, their in OR blood pressure. So the first blood pressure you get when you're entering the OR. I want to have a random sample of 10 cases per institution, and I want to look at patients that have a very high blood pressure to start, and I want to understand the quality of that data. So you can get it presented as this is the way an anesthesiologist is used to seeing the data. They see it, the intraoperative record for that patient. But you can drill down on samples of cases where you either are interested in why these patients are outliers, and it may be for a valid reason, or it may be for some reason related to data quality, and something that we can then improve using some sort of artifact reduction or phenotype to make a more reliable label for your data. One brief slide on surgical outcomes registries. So a couple different groups across the state of Michigan have agreed to work with our group to combine surgical outcomes. And these groups are the MSQC, the Michigan Society of Cardiovascular Surgeons, MSTCDS, and Michigan Value Collaborative, which is a group actually looking at cost data and integrating it with MPOG. And through this integration, again, we've been able to do different projects that we wouldn't have been able to do with one of these data sets alone. So take-home points, two. The first one is that we all know that electronic health data is messy, but if handled in the right way, it can be used to solve really interesting questions. This idea of digital phenotyping, I think, helps mitigate the problem of garbage in, garbage out. If you can create better labels for your data through synthesizing multiple data streams in a way that creates a higher level inference, that's a much better way to go about studying a research problem. And the second point is that accessing your data, again, should not be 95% of your effort. Just like University of Michigan Hospital Data Direct helps offer this platform, our MPOG group Data Direct offers a very similar platform for clinicians and scientists to speak the same language and interact. And then finally, the best opportunities for integration, or the best opportunities for developing research projects come from the integration of diverse data sets. And so being able to enable this through integrating with surgical outcomes registries has been a very important part of our collaborative. So with that, I'll take any other questions, and I thank you for your time.
Let's start with
Sure.
That mapping from the measured features to what you call standard phenotype.
Yeah.
The other names, right, these are programmed ways to do low-rank projection, and then there are the community-agreed labels. My question is, how often do you allow the change of that mapping rule depending on user-specified strata? Say somebody did a cohort for the white male of this age range. Do we compute that projection based on this more restricted learning set?
So what I would say, what we do is we want to get the data into the coordinating center as I guess as easily as possible, and we will I guess there's this idea of early binding versus late binding, where you force a label to happen earlier versus later, and we will whenever a site has a new concept, or practice evolves and there's a new specific medication or something, we will create that MPOG standardized concept, and even if certain sites don't have access to that or aren't tracking that specific variable, you can map to that concept. When concepts, I guess, change over time,
it's either change over time or that mapping function depends on the sex, age, or ethnicity. It's almost like a global PCA versus local PCA.
Yeah.
Would you recompute?
Yeah. So I guess what I would say, one of the things that we do, I guess the short answer is yes. We would do a recomputation of it. The longer answer is that what we've done is at each one of these sites, not only do you have to do the mapping one time at the beginning, and that's the majority of your effort,
Sure.
but each quarter we have the same clinician audit the mapping, and you can actually, using the Data Explorer tool, you can see if there's a sudden change in the quality of your data. We ask you to then go back and remap specific concepts. And it happens the most common time that it happens actually is if the hospital switches from one EHR vendor to another. It becomes your mapping becomes degraded, and you have to go back and remap a lot of different concepts. But we basically each quarter will have whoever is the kind of the point of contact, clinician point of contact at each one of these sites. They will have to go back and attest to the quality of their data, and if there is some aberrancy, then they will remap the concept. And oftentimes there is the case where you'll find over time the data will change, and you have to create a much tighter mapping scheme.
Right. Basically, my question is about algorithmic question about adaptable weighing of the feature primitives and the strata.
Yeah.
And then you also refer to how if patient had prior diagnosis or family history, that is giving greater weight.
Yeah.
Flow diagram,
Sure. Yeah. So I guess what I would say is we aren't yet at the machine learning phase. We're all of our algorithms, except for the CPT prediction one that I mentioned earlier, are still just rule based. And we'll refine the rules over time as we see better ways to do that. We haven't. I think that's a great opportunity is to do a machine learning approach where the different features have different variable importance. But yeah, I guess we're not yet at that stage. We're still at kind of a rule-based approach, at least for our own.
Even the rules is based on distribution. If it's on the details, you do something.
Yeah,
but
sure.
That distribution can be strata specific. Yeah.
I think I guess we there's a trade-off between generalizability and saying does this work for my own hospital's data set, and we try to favor generalizability. And a lot of these phenotypes too we found are used to develop your covariates for your project. If your project if your exposure variable for your research project is a phenotype, sometimes you'll find that the edge cases won't work perfectly. And so we usually have the clinician that's doing the research project work very hard to develop their exposure variable, and then all the phenotypes are used as covariates that maybe the 99.9% accuracy is okay. You don't need that 100%. But I think you're right. I think as practice changes over time, changing the rules does make sense. I guess we favor a more general approach that's applicable to multiple hospitals. I think absolutely.
Any other questions? Thank you.
All right, thank you.